to start. Anybody else see it that way?
Sure.
Well, welcome. It's great to see everybody here. Appreciate your coming. I'm sure others will drift in as we begin. We're trying a little bit different format this fall in our HIAC meeting. We try to meet in person when we can. That's been challenging of late. And what we're doing today is beginning a 3-day series. I think you've probably received a lot of advance publicity on that. But today we're having one of the presentations from a visiting scholar on a white paper that they've been working on, and we'll do the same thing tomorrow this time and the same thing Friday this time, just to put a little bit of a spotlight on the good hard work that they've been putting in with the center. And we're excited about that relationship, and I hope you'll get a chance to see why in just a few minutes. Our kickoff speaker is going to be Nilay in just a few moments. So Nilay, that was your cue to get teed up. Are there any questions for the good of the group? Before we begin, I want Nilay to have plenty of time. The format, in case you're wondering, for today and tomorrow, we'll have the white paper presentation first, followed by some remarks from someone from the center. In this case, today, I'll be speaking following Nilay. Tomorrow, we have Dr. Jay Maddock speaking. And then on Friday, we will adjourn the presentation from the white paper and move to the Friday lecture series with George and the cast of thousands that produce that event every week. And so that'll be fun to get the mix of venues and the mix of content. Well, as people continue to drift in, Nilay, I want you to have plenty of time. So as our first professional visiting scholar for this week, the first of 3 presentations, the floor is yours. Make sure we understand exactly about your work and what your interests are, and maybe in the Q&A session that follows your presentation, we can talk about how to help you or how to participate in the good work that you are doing. Nilay, it's yours.
Absolutely. I mean, oops, sorry, hold on. I shared wrong screen. I'll just move it over and move it over on the screen. Okay. Are you able to see my screen? No. Sorry. I will share the right screen. Sorry about that. Okay, you able to see my screen now?
Perfect.
Great, thank you. And thanks, Ray, for that introduction. I also have one of my colleagues, Kelsi, with me, and she will be co-author of this paper. This paper is by no means complete because none of you have seen it. This was our first go at it, and it's in kind of a draft format at this time. So we need plenty of your help to make this happen. And in terms of introduction, I am very happy to introduce myself as an inexperienced researcher. I heard somebody had a question or just sound, I suppose. So yeah, we both don't have much background in research. So we do need your help to finish up this paper or review it and do what you need to do to help us out. So this is a topic that anybody and everybody knows now. It needs no introduction because we lived through this and we are continuing to live through this pandemic. So of course, we all know what this pandemic has done to us. It has caused unprecedented level of health crisis all over the world, didn't spare anybody. And it has revealed several weak spots in our healthcare system. not only to the US, but everywhere else. And it has caused severe disruptions to the normal operations of all health delivery systems throughout the world. So in spring conference, we had I had posed a question as a proposal for this white paper is what is it that we can do as designers to ensure the continuity of normal operations of healthcare facilities during similarly large scale and ongoing event, because this first we thought would be over in 4 weeks, 6 weeks, 12 weeks, and now we are in the second year and it's still going on. So what is it that we have learned and what can we do to prevent something like this happening? The effect, how can we contain the effect of something like similar event in future? So that's the primary question. So if that's the question, what is it that what design measures and interventions that we can suggest that are affordable, practical, and implementable without overburdening the healthcare systems in preparation for an unknown future event? Because though we have had this, we don't know what the future event could be. We might be overthinking about COVID, and it might something else would show up in its own form, which we don't know. So how can we lessen the burden on the healthcare system to implement some certain strategies? So if we were to implement the strategies, they would have to be applicable to the existing stock of healthcare facilities. It's easy to say, let's do this, let's do that for new designs or renovation projects, but it's kind of difficult when we have plenty of stock of existing healthcare facility. So how do we prepare those facilities to face something like that in future? And again, my third point is make it affordable, because in the US, most of the healthcare still is in private hands or private organizations that cannot afford an investment into something that is hard to measure, and we don't know when the benefits and how the benefits would come out of that. So generally speaking, where did the architecture fail us? And there are many other subtopics, but if you were to pick top 3, the first one is we were not able to separate the infectious patients from non-infectious patients, and that has led to several issues. I mean, the whole coming down of healthcare system was related to that. Even when the person or a patient gets onto the campus, all the way to an isolation room or wherever that patient might have to go, throughout the system, we were not effectively at the beginning of the pandemic able to separate the patient population. In terms of design, so adaptability, so we were not able to adapt. Our healthcare systems were not easily able to change themselves to deal with the surge of one kind or other. They couldn't quickly convert something into a testing facility, couldn't quickly convert something else into an ICU or patient bed. So there was difficulty to use, even if they had space. For example, they had ORs that were sitting empty, but it was not as easy as to change it for some other use. And in terms of infrastructure, we all know that, again, same issue with the adaptability and the capacity, lack of oxygen, lack of other negative pressure rooms. So those were the other failures in terms of architecture. So key lessons learned, and this is kind of will get you into what Kelsi and I are trying to do with this white paper. So we were unable to contain the spread of infectious at the community level. And in our view, the primary healthcare facilities at local level have potential to break the chain of transmission by being able to test the patients and manage mid to moderate cases and only severe cases that require secondary or tertiary, that should require secondary or tertiary care. Majority of the primary care facilities were either not equipped, overwhelmed, which caused disruptions all over the system. So, for example, 96.7% of the hospitals either canceled or postponed the elective surgeries or non-surgical procedure with the intention of preserving their ICU bed capacity, PPE equipment, freeing up their staff, and reducing the risk of transmission. And dependency on supply chain, which is not directly related to architecture, but it kind of brought back the question of how dependent the systems were on the supply chain. Some hospitals didn't have 1 week supply of gloves to mask, and that kind of makes you question what we as architects can do if they were to bump up that capacity or dependency. So in the paper, how we are trying to address this, if the continuity of normal operation is the key question, how do we keep facilities running? What we have thought of doing is dividing the recommendations or suggestions into 3 groups. Primary care facility, which would be ambulatory clinics, urgent cares, EDs, and then testing and imaging centers. The secondary care facility, of course, are community hospitals, rural hospitals, and critical care hospitals. And then tertiary care facilities are the larger ones that cast much broader umbrella. So if this is the goal, the idea is, how do you protect these hospitals? Because first you should focus, or primary care facilities should be able to handle most of it if something like this happens. What happened during the pandemic, that it was the primary care healthcare facilities were not able to handle anything. Even when the first test kits became available, they were distributed to the hospitals. So that brought the infectious patients directly to the hospitals. Instead, if they were distributed to primary care facilities, you were in a way able to cut down on number of patients who would even go to a hospital. So the idea is, how do we protect the secondary care facilities so they don't get disrupted, so that they can continue to treat the patients that they need to. And same thing with tertiary care facility. They should not even be in the mix, ideally speaking, that they treat the patients that can't even afford any postponement of care that they have to have. So that's, and Kelsi would go further into detail in terms of paper, how we address these strategies as a goal. So I'm going to hand it over to Kelsi to talk about how we have formatted the paper.
Thanks, Nilay. As he said, my name is Kelsi Schwede, and I am a colleague of Nilay's at Shepley Bulfinch. And we wanted to spend the next part of our time with you guys today reviewing how we've chosen to set up and organize our paper. We are currently in the draft phase, and as Nilay mentioned, we are not experienced researchers and writers of this type of white paper. So we want to use this time to get feedback from you and hear about your thoughts, not only about the topics that we've been exploring, but also about the general structure and organization of the paper. So the basic structure of the paper is outlined here. It's going to start with an abstract and a problem statement, and then the majority of the paper will be focusing on our methodology, which is our research, the lessons learned, and potential strategies for different healthcare facilities to employ. And we'll kind of get into that as we move forward. But the structure then finishes with the conclusion and, of course, references and additional resources for our readers to access. So Nilay covered our topic, the interests that we've had and the research we've been focusing on. And through that, we've developed this problem statement, which is kind of a culmination of that and is driving the general direction of our paper. So most of the healthcare institutions have had to discontinue their normal operations, not only due to a lack of the space or shortage or supplies, provider shortage, but also due to an inability to separate the infectious from non-infectious patients. And this has resulted in postponement of care for several patients that has led to more acute health conditions. As Nilay was touching on, the postponement of a lot of surgeries, non-emergency procedures, but things that still have an impact on the health of a lot of patients. And from there, we've kind of created this objective, which is the question that we're asking, which is what design interventions and infrastructure provisions would be helpful to ensure normal operations of a healthcare facility during a large scale and ongoing emergency event in the future, such as a pandemic. So that's what we're trying to explore through this paper. So in order to develop this paper, we had to narrow down our scope and find areas to focus on because this is so broad. And to do this, we identified some assumptions. So as Nilay touched on, we're choosing to focus on 3 specific healthcare types: primary, secondary, and tertiary care facilities. This means that we're kind of not looking at facility types, including long-term care facilities or nursing homes. We recognize, you guys recognize that these facilities were highly impacted by COVID-19, but for the sake of narrowing our scope, we're not including it in the focus of our study. Additionally, we've chosen to focus our research on specific types of disease transmission. So that includes airborne and droplet transmission, waterborne transmission, and contact or surface transmission. We know how COVID-19 is spread rapidly throughout our communities and through our healthcare facilities. The next pandemic could be a different type of transmission, but there's lessons learned between all of these different kinds that we can learn from and prepare for the unknown in the future. So moving into the bulk of the paper, where we're exploring lessons learned and possible design interventions to combat future emergencies, we are exploring this through a layered approach. And Nilay's really touched on this for the primary, secondary, and tertiary care facilities. We've chosen to organize our paper through the lens of these 3 types because not every problem or intervention strategy is appropriate for all 3 of these types, nor is it always feasible from a space standpoint or a financial standpoint. But by layering it and kind of using these categories, we can identify unique strategies for each type and the strategies that may benefit all types or 2 types. So the primary care facilities are what we consider the front door to our healthcare system. They're where our providers are first coming into contact with patients. So clinics, testing sites. Secondary care facilities are our community hospitals, and tertiary is our specialty hospitals and academic medical centers that treat the complex patients. So they all impact each other, just as Nilay was touching on. If we could, let the primary care facilities do what they're best at and focus on testing and triage and the initial stages, and let our tertiary care facilities focus on the complex patients with extreme cases, that'll really let them all work together to provide the best holistic care across all of our population. So the organization of our paper in this way allows us to really identify some strategies for each type. So we've listed them here. Testing abilities, separation of flow, supply chain management. So what we really want to focus on is identifying strategies for each type that are affordable, that are implementable, and are practical. We've really tried to focus our research on what existing facilities can do in terms of minor renovation compared to what we would do if we were building a brand new hospital. So we want this to be impacting the facilities that we already have in place. Another organization method that we're exploring is using matrix like these to communicate the layered approach. So the goal with this is to demonstrate how not all of the strategies apply to each type. Another benefit of creating some matrix like this is allowing our readers to identify what might be applicable to their interests or their facility type, and then go to those categories to kind of zero in on the most beneficial information for them. And then the conclusion of our paper reiterates the value of identifying what worked and what didn't work during our experience in the ongoing COVID-19 epidemic and develop appropriate strategies and solutions to plan for the next one. We all know that there's many unknowns about what the next challenge will be, and we're certainly not through our current challenge. But as a healthcare community, we must be proactive and flexible to develop architectural design strategies that could help prevent future spread. So we all know that prepared and fast response is going to be essential to protect our communities, our patients, and our staff. And then the final component of the paper will identify resources, additional resources that readers can access on the different topics, a few of which are just listed here. So this is the general direction that our current draft is headed in. And like we mentioned, we want to hear from you if that makes sense, if it's digestible, if you think that that's beneficial. So Nilay is going to say a few more words and then introduce us and set us up for the Q&A session.
So not much to say. I wanted to have more time for discussion. So we'll open it up for Q&A, but what we always fear about that even if we learned a lot or we are learning a lot through this pandemic, we just don't know what the next one would be. Are we going to focus too much on this pandemic to create, even FGI is working on set of guidelines, developing set of guidelines. As architectural community as a whole, are we going to just learn too much and try to implement too much based on this pandemic? And then who knows, the next one, if hopefully there is none, but if there is one, could be of entirely different kind, then we'll be caught by surprise after making all this investment in terms of infrastructure and improvement in other direction. So that's all we have. And as I said, and Kelsi also said the same thing, that we are not researchers. And this is the direction that we are taking. And we would like to hear from you in terms of the direction, the content, what should we focus on? What are we trying to bite too much? All those things.
Well, Nilay and Kelsi, thank you both for your presentation. I appreciate very, very much the effort that has gone into this. And while people are collecting their thoughts, let me offer a first question just to sort of grease the wheels, and I hope others will speak up. But I'm curious, with your clients, Nilay and Kelsi, are you finding that clients are working on their facilities in the spirit of adjusting their operations to accommodate COVID, or are they adjusting their facilities to be more resilient, whatever the next problem is? Are they making disease-specific modifications or generic modifications with a longer view? What are you finding?
Okay, I'll go first, and then Kelsi could add with her experience. So again, and that's what I kept repeating, that these need to be affordable, whatever we suggest, because after all, a lot of healthcare is still in the private hands, or the organizations that are either nonprofit or they have to make it work year-to-year basis. So on the projects that I'm working on, there are definitely, every single time we have a meeting, we talk about what did we learn from COVID in terms of design, what are we going to do. But to my surprise, people are not quite there yet in terms of implementing too much more than very few things, such as waiting room size is going down. So with practice changing now, there are very few patients that wait in the waiting room. So in terms of their work processes, the work processes definitely improved. They have new apps to let the patient know, texting the patients, for example, that if the physician is running late, they would text the patient so that the patient is not in the hospital waiting or in the clinic waiting for too long. So their processes have changed, but its impact on design is to that degree. For example, the waiting rooms are getting smaller, or, oh, we need an isolation room. But it hasn't changed wholesale to say we need a patient floor that we can completely evacuate, or we need ICUs in the event of such a pandemic. Because who pays for ICU? Who pays for such a large investment to have a negative patient floor? Because when it comes to budget, that's going to cost a lot. And the benefit is unknown. You don't know whether this would happen again in next 40 years, or whether it's going to happen in next 40 years, or who knows when. So the strategies are being used again through financial constraints. It's not everybody wants to do the right thing, but it comes down to dollars.
Sure it does. Kelsi?
I was just also going to add that the time frame, in my experience, has been impacting the conversation. Some of the small renovation projects that we're working on that, you know, they want open by the end of next year, you know, we're really looking at a different conversation than the long-term projects that won't be open for 4 or 5 years. So the long-term projects, the clients are more entertaining just kind of general resiliency conversations, where the small renovation projects, we're doing a lot of quick implementations, more isolation rooms or more PPE cabinets, or the list goes on and on. But I do think that time frame of when it's going to open plays a big role on how much that is dominating the conversation.
Sure. Well, that makes sense.
This is Elisa with Gresham Smith. If I could offer just some experience with one client project that we worked on. We went on lockdown just as we were starting user group meetings. So we designed the facility all through the pandemic. So that was very much a big part of the conversation. And some of the accommodations that they made, this was a greenfield project. So it's not only is it going to be, we have a hospital, I think it's a 972-96, I forget the room count, but it's a good sized community hospital, and there'll be an MOB and an outpatient building on there as well. But some of the accommodations on how the conversation changed because of this was the mechanical systems in the facility. We're still looking at 10% of the patient rooms are for ICU. You know, the program didn't really change, but the mechanical systems did. So each floor, there's a maternity floor, a med surg floor, a children's floor, and an ICU. Every floor is designed mechanically to flip over to negative air at the flip of a switch. And then their entry sequence for the public has changed. So there's this procedure that everyone goes through, kind of like TSA at the airport now. So the vestibule sequence and the entry sequence has changed quite a bit. So everyone's coming through a vestibule, anticipating to get not searched and seizure, but you know, kind of like when you're going into the amusement park, your bags are searched, and then your temperature's taken and that sort of thing. So there's more room dedicated in the vestibule before you can even come into the facility. And I anticipate that process will change depending on the pandemic that we're facing, if it's an airborne or temperature related or what have you. But there's a large security presence in the lobby that doesn't have, you know, it's not a police officer with a gun that's standing there, but it's more of a, it's designed more to be like a concierge desk, so that you have more staff members present in the lobby than you've had before. And it's more of a, not only just a crowd control, but also just if people are concerned or anxious, they've got more people there to interact with the public and with families and patients to kind of put people's minds at ease. In the emergency department, I will be perfectly transparent with you. We were, as a design team, we weren't quite happy with the design solution we came up with, but they've implemented a mechanism in the architecture so that if they have to separate populations and control flow of the public through the emergency department, particularly after hours when the main lobby is closed up, then there are these glass partitions, that these movable walls that can close up and section off different parts of the emergency department. But when they're not in use, we attempted, and I wish we had a better solution, but they're meant to be more of a decorative artwork kind of thing, and not look like it's a very institutional, scary, we're on lockdown 24/7 here kind of element. But they are planning for if they need to really be concerned about dividing patient population because of airborne issues or such. So those are just a few of the things that we saw coming in this latest project. And it's so far in our office, that's the only project that we've designed that's been completely designed during the pandemic. There were some post-design adaptations to some of our other projects that we tried to implement on some other projects that were pretty far down the design road. But whether like the Shepley Bulfinch team mentioned, whether those get implemented due to cost, because it's a lot harder to go back in and add those design features once the building's already begun construction. So anyway, that was a little more than you probably wanted to hear, but just wanted to share some experiences that we had recently.
That's terrific, Alicia.
Thank you.
That's great to hear those things. Are there others on the line that could share stories from their experiences with clients? That was terrific.
Yeah, this is Dan Thomas. Right as the pandemic hit, we were in design for a patient tower in the Northeast. And so, flexibility and redundancy came into big question of how do we address the increase or the surge of the pandemic, and being able to convert our mechanical units, have that redundancy so that we can convert those units to negative pressure units for ICU patient beds. And then also, how do we use the ancillary space to create donning and doffing areas for the staff and supplies. So, the big question coming out of that project was flexibility, and how do we define what flexibility is, and how does the facility flex to accommodate these surges? I mean, because it's more than just COVID. It's like, fire and natural disasters, and how does those hospitals be able to flex to address those from a long-term standpoint? And then how do we embrace that as a design industry? Like you said, it's about cost. How much are the clients willing to pay to create that redundancy for the new facilities or for just their current facilities? So those are the things that we've kind of seen from HDR standpoint of where the COVID has impacted our design. So flexibility, and definition of flexibility, I'm still trying to figure out what that means from a facility standpoint, a site standpoint. We talk about flexibility, but what does that really mean, and how do we accommodate that in our practice in developing these spaces?
So true. Other comments from firms on their experiences, case studies?
I have a quick one. Everybody talked about the new facilities and what they are experiencing. I am working on 2 other projects where I'm experiencing ill effects of, so to say, of the pandemic, because the negligence of care has led to so much demand for cath labs and heart conditions that the people have developed just because of the lockdown and how much far we got in terms of our own health. So hospitals have seen such a spike in heart diseases, and I happen to do a lot of heart hospitals. So they are in there is such a demand now for heart disease treatments that they want these cath labs and ORs built yesterday. They can't wait for us to really complete the documents and build it 2 years later. They want it now. So those spikes that we are seeing is because of pandemic, because of the negligence of care. And that's what the theme of this paper was, in a way, to say, how can we continue to have these other operations go on, because none of the other diseases went on holiday because of the pandemic. They were still there and they got worse. So those are
Nilay,
the projects that we are working with.
that's such a great question, and I don't want it to just be a comment on your part. I'm going to revive it as a specific question to the group right now. How many of you are dealing with clients who are sort of weighing in the balance the severity of what they experienced with COVID and the severity of predictable, regular, and now unmet need? You've got this emergency response that shunted all these resources to a COVID response, while these other ongoing, predictable, regular needs for medical care went untended. How many of your clients are saying, we want to go back to being the provider of the people who trust us, who are in our community and so forth, and we're going to treat the next pandemic as an adjunct, and we don't want a strategy for changing the place where we do everything every day for the people that come routinely. We want a strategy for how do we provide a pandemic response alongside what we do routinely every day for the patients that we can anticipate coming routinely. How are any of you seeing clients take that posture?
So Ray, this is Charles with EYP. It's a great idea or notion that you put out there. I think that our clients are delighted to get back in the business of normal healthcare and relations, but at the same time, treating patients that have been afflicted with COVID is part of the new world that we're in. And we're seeing just a variety of responses from clients all across the country, from, oh, we don't think we need to make any facility changes because there'll be a vaccine that's going to eliminate this. That was an early spring of 2020 response from one of our clients, and there's some truth to that. We've seen the comment was made earlier about the expense of going in negative pressure in existing hospitals. That's a true statement. For the new work that we're doing pretty much across the board, all clients are looking at having a floor or more of being able to go all negative if they need to. We recently started a master plan with a client in the Midwest that had the wisdom to have their bed tower all be have the ability to get negative pressure. And that project was finished in 2015. So they were pretty prescient in their thought, and it really helped them through the COVID crisis and managing that. But I think some of the supply chain issues that are the just-in-time par deliveries, that's all being rethought. How do we need to restock and take care of supplies on our own instead of relying on other supply chains? So there's some movement in that direction from some of our clients that we're seeing. So it's just a wide variety to a very complicated situation. The other thing that's really fascinating has just been the emergence of telehealth during this time. We were heading in that direction, but it absolutely ramped up the telehealth visits that our clients are seeing. But that started at its peak and starting to drop back down to more normal levels. But I think I think it's here to stay, and our clients are all saying that. So that's just some comments from our perspective.
It's great, Charles. Thanks. Good thoughts. Anyone else?
Hey, Ray, this is Jason Harper from Perkins Eastman.
Yeah.
A couple of things on our end. We were commissioned to do dedicated kind of COVID outpatient clinics for health and hospitals here in New York City. They were pretty aggressive in wanting to get these things built during the pandemic because they realized that they had a huge influx of long COVID patients, patients who had recovered but had ongoing symptoms and required specialized treatment. So so we were able to build 3 of these last year in the city, and they're open now. So in some ways, that was kind of building a parallel facility to deal with a specialized population that results from the pandemic. The other thing I would say is that in our international work, there's just a recognition that this is here to stay, and that this pandemic, similar to past ones that have hit in places like Hong Kong or Singapore or whatnot, I think there's a growing recognition that the hospitals need to be able to deal with, the influx of a surge of patients, and they need to be prepared for that. So the future hospitals that we're planning for internationally just have this built in, and it's requiring, separated transportation, separated vertical transportation flows, separated, circulation pathways, coming into the planning, and convertibility of inpatient units to all negative pressure to be able to deal with a surge of patients, but could be utilized during normal operation for non-infectious patients. And in my mind, it raises a question about the past approach in the U.S. code of distributing, the occasional isolation room within an ICU or within an inpatient unit, whether that will change in the future to sort of consolidate and aggregate isolation into isolation wards as a whole, rather than one-off isolation rooms sort of distributed within the hospital.
Yep.
Very good. Very good thoughts.
Jason, may I ask, the international projects that you're working on, are they public funded or private?
Public. These are public systems. Yeah.
They're publicly
funded. Yeah.
I think that's where our challenge in the US is in terms of the funding, because that becomes the first hurdle.
Right. Yeah. That a lot of systems don't have the funds to invest in creating that kind of separation that they need within their existing facilities.
Yep.
And Nilay and Kelsi, this is Lu, and really nice presentation. Really enjoyed that. And as a researcher at Texas A&M, I'm interested in how we could work together in the future and identify the research directions we can collaborate in the future, and with the combining the researcher, designer, and the owner, and maybe we can identify the funding for collaborative design research in the near future. So for the white paper, it would be great if you can identify this kind of opportunities and directions as well.
Thanks, Lou. We definitely, if nobody else was going to touch on that topic, I would have asked that where do we go from here, and how, as a research white paper, the next step. So I definitely, the more we can talk to you, it would be better. In the first slide that I showed you, I'm proud to say that I'm not a researcher of any sort. So we definitely need to collaborate with you to take it to the next level. And I think that's a great idea. If we can find a funding source for something like that, that would be very helpful.
Yeah, and a lot of insights, and that's something myself could not dig into so deep to figure out what's going on in the in the hospital or in the design field. So really appreciate that. Thank you.
Well, as I look at the clock, it appears that our time for this segment is drawing to a close. I'm going to invite the people who are on to reach out to Nilay and Kelsi and offer to help, to participate, to share case studies. Collaboration is one of the things that we want to facilitate with HIAC. And Nilay and Kelsi, I understand how you feel about not being researchers, but there's tremendous value in what you're assembling. Understanding the case studies and the issues that are raised in case studies serve tremendous value to all of us. And so I would feel good about your contribution, feel good about what you have to say. Sometimes the most casual comment triggers an important research thought. So I, for one, value very much your contribution to the conversation today and encourage you to stay the course and collect these thoughts and put them together, because they will influence what the rest of us think and do. And that's a tremendous contribution. So thank you to you and to Kelsi. Thank you very much.
Thank you.
Well, then it's time for you to stop sharing, and it's time for me to begin sharing. And I want to start with that image. So I am going to go to this. All right, there I am.
That's a cute puppy.
Yes, yes, that is the master of the house, if you must know. That's Mr. Rex, if you must know. That is my daughter's dog, and he rules the roost. And happy to tell you that's the case. I was asked to share this slide with you. Some of you will enjoy it more than others, but it's one of the promo slides that we use in trying to build our following in social media. And you'll see, okay, you can only see the background. Can you see the slide now?
No.
Okay, then I'm stopping. And I'm going to share again. And maybe this time we'll get the whole deal. Do you see the slide now?
Not yet.
It looks like it's loading.
Wow.
There it is.
There you go.
Wow. I had no clue it would be that big. Well, back we are to the promotion for our social media stuff. And you'll hear more on that in the presentation in just a little bit. Is that a good view? Does it meet the margins? Is it clear? Is everybody good to see that? Cynthia?
It looks perfect.
Okay, thank you very much. So let's jump in and so we'll kick it off with this. Howdy, it's HIAC F21, and wonderful to see everybody here. It's been a long time since we could really enjoy each other face to face, and I hope that day comes again soon. In the meantime, we'll just take the fullest advantage we can of sharing virtually. I appreciate the visiting scholars helping us pull this format together. I do want to mention, I know that we have at least one new HIAC member firm with Perkins Eastman. Welcome to the family. I know we've got some people from Perkins Eastman on the call today. Carlos, do you want to say hello and introduce others from your organization? Jason?
Hi there, Ray. Hello, everybody. This is Carlos from Miranda with Perkins Eastman. You heard just a little bit ago the leader of our healthcare practice, Jason Harper. We are so thrilled to be part of this group. One reason being is because, and Jason even touched upon it, if you take a look at the entire envelope of healthcare and what it's doing just in the United States alone, it's impacted more than just healthcare facilities. And I think that Perkins Eastman, for one, but also all the other firms that are represented within this call, for instance, everything that we're touching right now is being impacted by not just COVID-19, but even the mentality of how to respond, how to react, and trying to do what we can as architects, as designers, as healthcare planners, to actually get away from being reactionary. And I think that that's what programs like what we just got finished going through today with the white paper presentation and all the other conversations that will come up from this point going further through 2022. We're really excited to be part of that, because internationally speaking, yes, it's very easy to say that we're not just talking about healthcare facilities as a practice. We're talking about global architecture inside and out. And what we're doing as healthcare practitioners, I dare say, has an impact to how we're designing everything from this point going forward. So Ray, everybody at HIAC, thank you so much for this opportunity. We're very, very pleased and honored to be part of this group.
Well, it's great to have you. Jason, did you want to say anything?
Yeah, I was just going to second what Carlos said, that we do have a lot of other practice areas here within Perkins Eastman also, and we've been with the healthcare practice has been collaborating with our senior living folks and our higher ed and K through 12 practices and things like that to sort of spread the expertise and help advise them on what they need to do in their facility types as well. So it's an interesting kind of crossover going on around not just COVID, but general safety related to infectious diseases going forward. So
well, it's wonderful to have y'all in HIAC. Thank you so much for the support. I'm not aware of any other newly joined HIAC member firms. Does Cynthia, do you know of any others, or others from the center? I think Perkins Eastman is our new firm for this time around. And I just don't want to miss anybody, but I'm not aware of another firm that's new right now. All right, well then let's keep going, and I'll put up a couple of more things that you may not want to answer now, but which I want you to be thinking about and maybe answer later in the Q&A session. One is, how do you feel about the new format, this idea of a research paper with discussion and then an update on the center? You'll have more to base that answer on after I've done the center update. And then ideas for other things that we could couple in this format, content and then update, content and commentary, that kind of thing. We would welcome input on how to make that even more valuable to you. I'm excited about this week and hearing from our three scholars, but there are other things we can do too, and we'd love to explore those possibilities with you. So let me jump to the agenda for the main content. There's some professional excellence that I want to bring to everybody's attention. I want to update you on things that are happening with the College of Medicine here at A&M. And I want to provide a social media update. That will be done by the lovely, the capable Cynthia Lockhart. And after she finishes, I'll do the 2022 UIA Year of Design for Health update. And what I really want you to listen for in that is an opportunity to take advantage of something that could be of great value to your firm. So without a lot further delay, let me jump right in on covering this. This is a time to celebrate good news. Some of you actually have worked with Shumei. Shumei Zhu is one of the core faculty of the center, and she was recently recognized as a Presidential Impact Fellow. This is an award that was created by a previous A&M University president, and I left that text. I know text on slides is a no-no, but I left it because the words are just so overwhelming and positive. I wanted you to see what was being recognized about Shumei. She's one of ours. We cherish her contribution. Her research is exceptional. She's a great teacher, a great team player. So It's wonderful to have her. And I wanted you to know this about her, especially those of you that have worked with her. She has been named a Presidential Impact Fellow. That is extremely high praise here in Aggie land. And I know you'll be pleased for her. I just wanted you to have that in your thinking. But I also want to call attention to some more folks. You just heard from Nilay. I'm going to have a slide here for each of our professional visiting scholars. This is something that we introduced fairly recently. It was just an idea that we had for how do we make research more a part of our firms, our network of firms? How do we create further dialogue between the center and our HIAC firms? And the professional visiting scholar, just to be sure everybody understands, these are from HIAC firms. These are firms first that choose to belong to HIAC. And they pay an additional fee to name a professional visiting scholar. Now, visiting scholar is a position the center offers. We have three kinds. We have an academic visiting scholar. That's somebody from another university that wants to come and shadow and study and maybe do some research while they're here. We have research visiting scholars, people that come and do research of one sort or another here while they're here. The professional visiting scholar is coming from our HIAC firms. We have three firms that have stepped up and done that. And this is a firm that says we recognize the priority that research is taking in the profession. Research-driven design, evidence-based design, research-influenced thinking. How do you build a design hypothesis? How do you test it? How do you do all of those things safely and smartly? And how do you share that with the profession? How do you take the position that being a thought leader across the profession and the client base by reputation is of greater value than one little piece of proprietary research discovery that immediately is public knowledge as soon as the project opens? These are firms that have taken the big view. They're just tremendous in their desire to lead the profession, and kudos to you. So we have three. You just heard from one. You'll hear from the other two tomorrow and Friday. Tomorrow you hear from Lisa LaRusso at Gresham Smith. They have made a similar commitment, and Lisa will be sharing her research and the research that's being done at Gresham Smith tomorrow. Looking forward to that, Lisa. We've had other conversations, and this is a relationship that is blooming the way that we really want it to. We would love for the other HIAC firms to join. The research, the professional visiting scholar relationship with the center is really dynamite. To pursue the impact of research in design, in practice, and to do it between the center and one of our firms, it's really a very special treat. So we'll hear from Lisa tomorrow, and then running the anchor leg is Dan Thomas on Friday from HDR. And you'll hear about a white paper that he's been developing with our own Bill Ide. So just a congratulations to the individuals who stepped up to build the relationship. If you're not familiar with this relationship, a professional visiting scholar gets access to every research resource that A&M can offer. It's a remarkable peek behind the curtain. I mean, it's more than a peek. It's come on back and live here for a while. So access to everything in the library, the research the centers are doing, the white papers that are in the development, any of the research activities at A&M are accessible by professional visiting scholars. The visiting scholar place at A&M is well understood. We've attached it to a professional relationship, and they move freely among visiting scholars around the campus. So For the rest of you firms, please consider it if using research, if accessing research materials, if buying access to research piecemeal is becoming expensive, professional visiting scholar can access everything, and through the A&M library, anything in the world. Give some thought to allowing that to then permeate your practice with a research mindset. It might be transformative, and we'd love to work with you to help make that happen. Okay, so the next thing that I want to update you on is the College of Medicine relationship. Now, as you know, the center lives half in the College of Medicine and half in the College of Architecture. We are in our 37th year. That's hard to believe, but it's true. And in those 37 years, we had a primary emphasis in medicine in the early years. It transitioned in the mid-90s with Roger Ulrich and Mardell and Kirk in the leadership roles here, Kirk Hamilton. It transitioned to the College of Architecture, and our office still physically is in the College of Architecture. But in this past year, we reached out to the College of Medicine and said, you know, this is silly. Shouldn't we be really doing more together? And the College of Medicine jumped on it. I mean, with both feet. They have a newly named dean as of last December, who is phenomenal, Dean Amy Ware. Dr. Ware is a surgeon, and she is wide open to collaborations with architecture, some very exciting things happening. And I want to share that with you. And the back message that I want you to get as a HIAC firm, the back message is, this is the transition. We're building the bridge we've talked about into the provider side. So a HIAC firm is going to be front row to this emerging level of activity in the College of Medicine and things that they're studying, where design has a place to play. And as I run through the things that are happening right now, I want you to be asking yourself, do we have clients that do that? Do we have clients that are interested in that? I think you're going to see a lot of opportunity for greater collaboration and greater value in being part of HIAC. So let me jump in. The College of Medicine is built around 3 areas of emphasis. And I'm going to walk you through those 3 areas of emphasis right now and talk about each one. And again, I want you to listen to see if any of these areas line up with what you're doing in practice. If they do, I want to hear from you, because I want to try to get you plugged into some of these activities, in a most appropriate way. To kick this off, the College of Medicine, and I should broaden that to say A&M Health, is really working to collaborate with us. Just recently, Kirk Hamilton was granted a faculty appointment in the School of Nursing. I was granted an appointment in the College of Medicine. I already had an appointment in the School of Public Health. Think about that for a minute. Architects, appointments in medicine, public health, and nursing. It's remarkable. We are plowing some really very exciting new grounds, conversations that we have not historically been having. The first area of emphasis is rural and community health. Now, I'm not where I can see hands go up, but I'll bet I'd see hands go up all over the screen. Lots of people trying to figure out community and rural health. There is a research and a clinical component to this. This actually is the division where my faculty appointment lives. So I direct report to the person who's leading this effort, who happens to be really, really excited about what this collaboration can mean. The support from the College of Medicine for these new horizons has been unbelievable. The other day I was on a Zoom meeting with them to talk about something that I'll get to in just a moment. And I think there were 8 or 9 people from medicine on the call, all of them excited. This is not something we're having to push the rope uphill. They are all on board. So if you start to hear opportunities for collaboration, research, joint initiatives, that sort of thing, speak up. This is an exploding frontier. So rural and community health, looking at how do we use telemedicine to get into the rural communities? What's the new model for the community hospital? What does it really have? What does it not? Where do these facilities fit in the network? Is there, I mean, to illustrate the illogical extreme, what if you put everything in healthcare for the economy of scale? We put all of the tertiary stuff in one location. Travel, time delayed for treatment, all of those sorts of things, support services that wouldn't make any sense to anybody. So then the question is, how many distributed nodes do we need? Do we need 3? Do we need 1 in the 4 corners? Do we need 4 plus 1 in the middle, a 5? How many do you need? And if we're going to add to that distributed networks, what is it that really needs to be handled locally and what can be transported? How much of this is being driven by business? How much of it is being driven by the medical model necessities? If you'd like to get in on that conversation, let me know. That conversation is roaring around here, looking at rural and community health and telemedicine. Oh my goodness. Where do all of the patients refer to on this concept of a distributed system? How do we plug providers into that? How do we rationally approach payments across state lines, for example? And there are all kinds of other little technical things, logistical challenges to making that work, but we're playing with those here. So let us know if that's of interest. Second area of emphasis in the College of Medicine is military medicine. Now, I know I'm talking to people from firms that are doing projects for the military or for the VA. I know you're concerned about PTSD. I know you're concerned about the suicide rates. I know you're concerned about design that's restorative to providers that are under extreme pressure. There are a couple of areas that are already underway there, and I've been assigned to the military medicine initiative. I've been assigned to that because of some things I've done in the past with the military and military healthcare. One of the things that we're looking at is, and in fact, in military medicine, there's actually something that you study. There is a training camp where you go learn. I mean, this is not something incidental. This is mainstream in military medicine called austere medicine. And we all got familiar with it during COVID, right? We saw hospitals doing what they do, and we saw curtains as walls, not curtain walls in the true sense, maybe, curtain walls in sports arenas, auditoriums, ballrooms. We saw curtained wall cubicles providing levels of care under some pretty bare circumstances. We saw technologies that were not beautifully installed with greenfield hospital designs. We saw things appended and inserted and taped on to make things work. Austere medicine is something the military folks actually study. So my earlier question about how much is the healthcare system planning for austere delivery, you know, reality check for a moment. Austere medicine during COVID got paid for. Somebody said that meets the standard of care, we'll approve it. Austere medicine. How long before an owner says, what if we offered austere medicine at a lower cost basis and took the cost difference, instead of putting it in 30, 50-year buildings? What if we used it for community health, for wellness, for activity, physical exercise programming, community planning initiatives? How long before somebody says, maybe we could do greater good if the inpatient portion was more austere and we had more working capital for other things? Somebody's going to chase that. I've already had these conversations with FGI, with leadership there. That question is real, and we're going to have to come to grips with it. Okay, so if you're dealing with military, if you're dealing with clients asking questions about austere medicine, let us know. We're right up to our eyebrows in the middle of that. The other thing that we're doing, we're working on a CRADA, Cooperative Research and Development Agreement, to look at modular health. I know, hold up a hand if you've had a finger in modular design. I mean, it's on everybody's tongue these days. And modular design, these are units that can be completely self-contained, HEPA filtered with UV as needed on the incoming air. The exhaust air is HEPA and UV as needed. And inside it can be configured for surgery. It can be configured for isolation. It can be configured for troop transport. But modular health units, they'll slide right into a C5A, get to where they're going, slide right out, boom, ready to rock and roll. Power supplies that are made available to these units. It's amazing. But this is a defense contractor that's excited about a relationship with A&M, taking this thinking and this kind of technology to the next level. You're dealing with people that are modular, looking at modular care, portable modular units that could be deployed in communities. Again, these are exciting things and they're real, they're happening. This collaboration with medicine has turned into be so much fun, so exciting. And they're as excited about it as we are. So let me hear from you if these are things that are of interest to you. Now, the last thing, the 3 areas of emphasis, the med school has this thing called MD+. And MD+ is where a student goes through, gets an MD degree and something else. So you may have heard of the A&M program in med, engineering and medicine. Somebody goes through the MD program with enough blending of curricula that they get an engineering degree when they finish the MD degree. And now they're looking at MD plus an MBA, MD plus a Master of Public Health. And we're looking now at MD plus architecture. The school has put together a proposal that will go to Austin, hopefully for approval. And we anticipate that because it makes so much sense. But we've put together a proposal for an MS with a limited number of credit hours, an MS in technical architecture. Health was put forward as the prototype to build the template for this new degree. The concept is the MS in technical architecture has a core plus electives, and the electives allow you to specialize. Well, in our case, the prototype was electives related to health. So what we're working through now is how do we get medical students to come through and get another degree from architecture? We're not aware of any program offering that. So there's a high level of excitement that this could differentiate, further distinguish Texas A&M in the academic landscape. And along with the dual degree, we're looking to make sure med students can get our certificate from the health systems and design. And this is neat, we're building a whole inventory of continuing education ideas to go out to medicine. Now, I'm going to throw this out to y'all. How many of you would like to participate in offering continuing ed content to an audience of physicians? I mean, imagine the credibility, imagine the pollination, the conversations, the discussion afterwards, and the follow-up with attendees. This is a fantastic opportunity for HIAC. I want you to be excited about it. We see tremendous potential. So as we move forward, we'll be kicking it back to you. Now, I've talked way more than I thought I might. I know that comes as no surprise to some of you, and I apologize. But it's time for Cynthia to update us on social media, and I still have the 2022 Year of Design for Health after this. So Cynthia, take it away.
All right, thanks, Ray. So I'm going to give y'all a little update on our new social media campaigns that we started back in August. If you can forward to the next slide for me, Ray. So since we've launched on August 23rd, we've actually seen really robust growth. We're really hoping to build upon that solid foundation and recruit more students, more HIAC members, and more fellows, and really be an integral part of putting together research collaborations, and other things of that nature. So at this point in time, we are on Facebook, Instagram, and LinkedIn. We can move to the next slide. What you'll see here is our rate of growth from the date that we launched. It is as expected. It is really strong on LinkedIn, where we have all of our professional collaborations. It's also strong on Instagram, where some of our younger generation, our really interested prospective students are. We've actually gotten quite a few messages from them. And then on Facebook, you'll see spikes where we had collaborations with, for example, student organizations and things like that. So overall, our growth has been looking really good. Moving forward. So what's working for us? We've been doing event announcements. We've celebrated Halloween and all sorts of different things. But what we found really works for feedback for us is personalized content. So that means content that features our faculty, our staff, our professional visiting scholars, our fellows. Those are the highest rates of engagement, because not only are we presenting something that interests people, we're also tagging those individuals and they're sharing it with their own personal networks. So we see a lot of engagement with those. Moving forward. So what does that look like? Here are 3 of our highest scores as far as engagement goes. Again, congratulations to Zime for her Presidential Impact Fellow Award. That got a lot of hits because people are excited when we're doing great things. And those are the sorts of things that we want to be highlighting every day on our social media platforms, including our HIAC members' successes. Your successes are our successes, and we want to make sure that we're collaborating to really highlight those on all of our social media platforms. We've also been doing a really exciting campaign called How Are You Designing Your Health?, where we ask our faculty, our staff, our student workers, what they're doing in 2021 to, better restore, preserve their health, and what they're doing. And it ranges dramatically from eating vegetarian to going on hikes. And it personalizes these people that we work with every day. And then finally, you'll see Dan Thomas's face. We have been doing a professional visiting scholar spotlight, a quote about why designing for health is important to our professional visiting scholars. And we're also collaborating and linking their firms within this content. So moving forward, what are we going to do next? So some of the things that we can do is invite you to follow us on any or all of our platforms. We are at TAMUCHSD on Facebook, Instagram, and LinkedIn. You're welcome to follow and connect with us. We want to really build our following so we can get the word out to more people and continue creating engaging content, which includes the campaigns that I just talked about. And we're also looking at doing prize-based content for our students, photo contests and that kind of thing. We really want to celebrate our HIAC firms by building joint initiatives and cross-posting, making sure that we're all talking together and kind of celebrating everyone's wins. Moving forward. So that's pretty much it for me. If you have suggestions, if you have questions, if you just kind of want to link up and talk, you're welcome to give me a call, send me an email, friend me on Facebook, or connect with me on LinkedIn, and all of my information is listed there.
Thank you, Cynthia. And I'm going to leave that for just a moment before I click over and say just a word. Cynthia, as I think some of you know, officially started toward the end of December last year, and is now coming up close to a year with us. She has been transformative for our organization. We are so pleased to have her. She is a wizard with technology, and she's creative. She's got an artistic eye. She technically, administratively is proficient in the extreme. Any of you who have dealt with her already know that. But I just wanted to take another opportunity to say welcome to Cynthia. It is really fantastic having you. We're delighted with your addition to the team.
Thank you.
And lastly, 2022, the year of Design for Health. Some of you know about the UIA, the International Union of Architects. In that organization, there is a group called the Public Health Group. Historically, that's been about healthcare. Historically, it's been mostly about healthcare facility design. In recent years, it has migrated. In 2020, we changed the focus of the public health group to be about design for health, not health care. We extended to the UIA public health group the 3 areas that A&M is focused on: the protect health, develop better health, and restore health once it is impaired. And they embraced it. It became the marching order for the public health group and has begun to define the activities that the public health group is undertaking. Very exciting, and it's going to create some extraordinary alignment between the international activity and thinking of the PHG and the activity and thinking of the A&M Center for Health Systems and Design. Last July, it was supposed to be the triennial meeting in 2020 in July. It ended up being 21 because of COVID, but at that meeting, a declaration, a proclamation was introduced to the General Assembly of 104 nations from around the world, the member nations of UIA. And without a dissenting vote, the declaration, the proclamation was passed. No dissenting votes, keep that in mind, to declare 2022 the year of design for health. But it didn't stop there. There was a full proclamation with goals and things we wanted to accomplish and so forth. I had the pleasure of drafting that proclamation jointly with the president of UIA, and he was very helpful and very supportive in getting it passed through and approved. So let me share with you some of those high points. And I want you to be thinking, what could this mean for our firm? First thing, to encourage the use of evidence-based design among practitioners and clients. So this is a chance to carry the message to clients if there are clients who need to be encouraged about this message and about your use of research. It's a way to point to being mainstream on the world stage. Second, we were challenged to launch an open access digital information hub. You can read it. Basically, they're saying you need to create a portal where any and all architects from around the world and anybody who needs to understand what architects are doing from around the world, we can all go to get more information. At least launch that in 2022. Also, an international research agenda. What is it that we need to be studying? What is it we need to be looking at? And lastly, support the creation of things, tools, resources to do research, to help practitioners conduct research. Now, I just want to say, when we first looked at this, we thought, oh, this is wonderful. 3 discrete things: online portal, international agenda for research, and tools to help the professional. Let me suggest to you that that is extremely challenging. As we've gotten into it, this is what we have found. You think about open access information hub. Does somebody in a developing nation who is concerned about waterborne diseases where people are bathing in the same water that they drink and that the animals use? Are they concerned about whether the HEPA filter has a UV light or not, or exactly the proper placement of an alcohol dispenser? No, their idea of designing for health is help me create cisterns and water retention systems so that I can drink pure water and not lose our next generation of babies to diarrhea and dysentery and all sorts of other illnesses that children shouldn't have to face. You think about the same level of disparity in the international research agenda and the tools. What tools would you use to measure compliance with the maintenance of a sophisticated HVAC system in a tertiary hospital compared to the tools you would use to see, is the water clean enough? Are we capturing enough for this community? Are they having equal access to it for their own health and dining needs? The range is unbelievable, but we have a year and support of an international organization to say this matters. And we don't have to finish everything in a year. It's a year to launch initiatives that could change our planet. I have to say, this is how we're viewing it here. Remember, the center is the secretariat for the public health group. So we're at ground zero of all of this activity. And if you look at those three things, the fourth, if you include evidence-based design, research in practice as a way of doing business, if you look at that, we are poised to change the world, and we're committed to doing that. This is an exciting frontier. One thing is already underway, and it's not too late for you to get in. So take note. The logo competition. This is going to have a logo, much like the Olympics logo is the one I use to illustrate the point. There's going to be a logo for the Year of Design for Health 2022. It's launched. The submission deadline is in almost 2 weeks, a little under 2 weeks. You've still got time to put something in, and the winner is going to be announced December 15th so that we can have it for the year of 2022. If you want more information, there's the website. It's just the UIA website. If you type UIA architects, then spelling is not quite as much of an issue, and it'll take you to the right website. But that's a way to get more information. If you and your firm might like to collect some entries and get them submitted, it could be a lot of fun. So as we come to a conclusion, again, I want to say thanks to Cynthia. She carries a great burden in pulling these kinds of things together. She's done it well. I'm grateful to her help. And it's time for questions. I hope that you will speak freely. Would love to hear from you if there are questions.
Ray, it looks like George has a question.
Well,
very well, speak up.
Yeah, I'm sorry I was late. I was at a college tenure committee where we discussed 3 candidates, and I was on my computer with them, and I was on my iPhone with the HIAC meeting, and I just joined, and I think you've had a wonderful meeting. I would like to take a moment and specify that on Friday, the lecture series will be together with KMU TV in our series, and Harold Adams, Chairman Emeritus of RTKL, will be introducing a team from RTKL in Dallas, and also a Patrick Casey, who's going to fly in from Miami, University of Miami. And they're going to talk about collaboration, which is the theme. So you're all invited. It was specified on the invitation, but I thought I'd fill in the details for the people on. I see that there are 23 people on. That's wonderful. So welcome, everybody. Sorry I joined late. And that's it. Thank you.
Always great to have you, George. Any questions about how your firm can participate with those initiatives in the College of Medicine or in the Year of Design for Health? Both of those are huge developments in the life of the center. We'd love for HIAC to reap the full benefit of it. Feel free to ask a question or to correspond with me after the presentation. I'll be happy to entertain those questions. Are there any now that we could answer to get the ball rolling?
Hey, Ray, this is Jason from Perkins Eastman. I have a question.
Yes, sir.
The Rural and Community Health Initiative within the College of Medicine, how focused is that on population health, the social determinants of health, the impact of design on social determinants? Just curious about that.
There are 2 groups working on the subject. Jason, it's a great question. There's one group focused more on the clinical side, and they're looking at how do we actually deliver primary care to these underserved areas that really can't justify a hospital, but they need more than, somebody's standing on the curb with a box of Band-Aids. They need more than that, but it's hard to know exactly what. And there's a clinical component to training people to work in that environment. The other major piece of this initiative is actually looking at the delivery system. And they're looking at, and frankly, the network of facilities in the work of this institute reaches well outside of Texas. They're scattered around the US. And what they're studying is, how do we keep this thing open? Are there services that we really don't need? Should we be putting in a trauma center with holding rooms, or a trauma center with 2 overnight beds? You know, how do we maximize the reimbursement? How do we make sure these things can stay operational and stay solvent? How do we make sure that the community network is in place? And, you know, they run into stuff, Jason, they run into things where neighboring counties, where it makes absolutely perfect sense to put a hospital between them. There's land even available. And you get some county judge who says, well, I'm not sure in my hospital with that county. And the other county judge says, oh yeah, well, we don't need you either. And then you end up with redundancy, and things fail, and they don't work, and they don't collaborate. And, you know, small town politics are really alive and well. And so it branches beyond just the clinical to say, how do we actually make this happen and work and survive? It's facilities, it's politics, it's mobile, it's telemetry, it's telemedical, it's all kinds of things in the delivery system. So both pieces exist in this initiative, and I'd be happy to plug you in wherever your interest is more closely aligned.
Okay, yeah, I was thinking more about you know, things like other aspects outside of the clinical delivery or the healthcare system that affect public health, like, you know, access to recreation or transportation or walkability, or, you know, active design, or the other ways that the design community and architects can impact public health with, but not directly through clinical delivery.
Jason,
I'm just wondering if that's a subject that comes up.
I don't have to send you to the College of Medicine to work on that.
Yeah.
The work that Shepley and Zipeng, I believe he's on the call, and Chanam Lee, 3 of our strongest researchers on active communities, healthy communities, designing for healthy communities. That's a combination of architecture and landscape with exceptional research skills. If that's your area of interest, within the College of Architecture, we've got some of the finest looking at those sorts of issues. Of course, the public health, we have a strong relationship there. They are looking at similar issues. We can plug you in. If that's your area of interest, we've got connections to offer you.
Great, thank you.
You bet. Just follow up with me. We'll make those connections, Jason. Happy to.
Yep.
Other questions, comments? Well, as we bring this to a slow close, and I can go ahead and pop out of the share. As we bring this to a close, let me just say again, 2 huge initiatives in the center. One is these emerging projects with the College of Medicine, with military, rural. Those are areas that I know touch a lot of the people involved with HIAC and HIAC firms. The other is the emerging relationship with the 2022 Year of Design for Health. Give some thought to what your firm might do that you could look back on as having started in the Year of Design for Health, like maybe a forum with your clients. Invite the top leadership of your best clients to a forum where a speaker or a guest or a theme is brought to their attention, to their discussion, to discuss the benefits or potential impact on serving their communities, or a product or a scholarship or some relationship with the center that you would like to inaugurate in 2022 as a benchmark in time. We launched this initiative in the year of Design for Health and have sustained it in the years since. Give some thought to that. We'd love to brainstorm it with you and help you come up with something that can sort of carve your niche in the year of Design for Health and cement that visibility and that alignment with that priority going forward for decades to come. We'd love to help you work on that. Okay. And if you've got questions that occur to you the minute we hang up from this Zoom call, as is so often the case, then just send them to us and we'll be as responsive as we can. Thanks to everybody who came today. Thanks a whole bunch. It was fun having you. Anything else?